welcome back to the Clinics Review Articles podcast. I'm John Vasello, Senior Clinics Editor at Elsevier, and I'm here with my colleague, Clinics Editor Megan Ashdown. Joining us today is Dr. Joel Heidelbaugh, Clinical Professor of Family Medicine and Urology at the University of Michigan Medical School in Ann Arbor, Michigan. Dr. Heidelbaugh serves as the Consulting Editor of Elsevier's Primary Care Clinics and Office Practice and is the Editorial Advisor for our Clinics Collections. The Clinics Collections draws from Elsevier's robust Clinics Review Articles database to provide multidisciplinary teams with practical clinical advice and insights that can be implemented in individual specialties in everyday practice. Today, we're discussing 4 articles out of the 28 that are in our latest edition of the Clinics Collections on breast cancer that published in April 2024. So let us welcome back the Editorial Advisor for our Clinics Collections, Dr. Joel Heidelbaugh. Hi, Joel. Great to talk with you again.
Hi, thanks for having me.
Well, we're going to go with the first question. Will come from Megan.
Yeah, that's my cue. So the first article we want to explore is titled Breast Cancer Screening Modalities, Recommendations, and Novel Imaging Techniques by Dr. Nielsen, I hope I'm pronouncing that correctly, and Dr. Narayan. So the research indicates that mammography screening reduces breast cancer mortality. Can you explain how mammography plays a role in early detection?
Sure. So with the advent of mammography decades ago, this was really a way to identify a challenge in diagnostics, meaning how do we best screen people for breast cancer, but how do we offer it to the general public? And since then, there's been a lot of guidelines that have been written and a lot of work in guidelines. So mammography plays a role in the best early detection because as a gold standard test, it's certainly easy, it's available, it's covered by insurance. I'll talk about guidelines in a second, but even the accessibility has been greatly enhanced. Okay, I'm fortunate enough to work at a major medical center, University of Michigan, and I work in a satellite clinic the town over from Ann Arbor, Michigan. And in our parking lot, we have a mobile mammography van that's there 3 days a week. So the accessibility has really ramped up as well. It's considered a gold standard based on decades and decades and decades of utilization, high detection of early cancers, and the ability to basically risk stratify women across a population. So if you look at the current guidelines, in 2023, the U.S. Preventative Services Task Force issued a draft recommendation statement that all women should receive screening mammography every 2 years from age 40 to 74. There's a number of guidelines, but this was an updated guideline, and in primary care practices, this is one that is highly utilized.
Yeah, I wasn't aware of the accessibility aspect. So you mentioned a few reasons why it's considered the gold standard. Would you say accessibility is at the top of that list?
It is, but also certainly the technology and just decades and decades and decades of not only utilization of the technology, but improvement of the technology to be able to detect cancers and detect them early.
We talked briefly about this off screen, I guess you could say. But out of my own curiosity as a woman, as a patient, I'm curious, how does a woman perform a self-exam for breast cancer detection?
Sure. So, the concept of self-breast exams has been widespread, used going back decades, but also entered into a period of controversy. So right now, the recommendation for self-breast exams is a bit limited. I'll also couple that with, without giving away my age here, I'll just say I've been in practice for decades, and I'll leave it there. But when I trained, it was customary during annual exams to have doctors perform breast exams on women and to counsel them on self-breast exams. Over decades, the evidence for that has waned to the point that we no longer do them commonly for yearly exams for women. And we also no longer recommend self-breast exams to be done routinely. That's not to say that we're going to tell you necessarily, no, don't do it, but it can be fraught with a lot of misinterpretation, and it can be fraught with a lot of raising anxiety in patients for unnecessary testing. When a woman asks me what she should do, I'm still going to say I think you should be familiar with your body. If you have a question about how to do those exams, we can certainly teach you. But the challenge is there's no real recommended codified guideline even on how to do them or how often to do them.
The article also mentions that women with risk factors for breast cancer may benefit from earlier supplemental screening. Could you elaborate a bit more on what these risk factors might be?
Sure. I think it's imperative to take a thorough history in patients, women, but also men who to find out what their family history of cancer might be. We're lucky enough now that with advanced testing and technology, it's pretty easy, not only in a major medical center, but through other labs and other practices, to be able to engage in genetic screening and genetic counseling. And there's testing that can certainly be done to see if someone is at risk if they've had a family history. Typically, what we would do is we would also consider starting screening at an earlier age outside of a guideline. Okay, so for example, a couple of weeks ago, I was doing an annual physical on a patient of mine I've known for a long time. She's in her 30s, but her mother was diagnosed with breast cancer at, I think it was 45 or 46. So then the question is, well, what does that mean relative to guideline screening? And in further investigation, she said, I think a couple of my mom's sisters also had breast cancer at an early age, but I didn't know them well, and I don't know what age they may have been impacted. So we talked about how her particular situation would fall outside of guidelines for earlier screening, and we did get a mammogram on that patient. But I also referred her to a genetic counselor for genetic screening, just to determine her risk.
And how might these risk factors impact screening recommendations? You talked a little bit about it and gave a case study or an example, if you will. Do you have any more thoughts on that?
We're going to look at age, if in this case a woman, but certainly if we knew a man's history as well as earlier, but focus more on women for this discussion, had a first-degree relative or multiple family members with breast cancer, certainly earlier screening is recommended. And again, getting back to accessibility, it's certainly easy enough to do. So we wouldn't wait to say necessarily, well, you're too young. Okay. And I think also that screening, could be coupled with discussion about an examination in the office.
With that, I'll let John take it away.
Yeah, let's turn to the article, Disparities in Breast Cancer Outcomes and How to Resolve Them, by Otis Brawley and Dina Lanzi. The authors write, in the Western world, breast cancer is the most common lethal cancer in women and the second leading cause of cancer death behind lung cancer. And while there's been a 40% decline in mortality over the past 3 decades, a review of population data shows that not all populations have enjoyed progress equally. So which populations have not benefited as much, and why? What are the reasons for these disparities?
Sure. Well, I think the Affordable Care Act took a quantum leap forward in terms of accessibility for patients to get health care. But just because somebody has insurance doesn't mean they get health care. And just because they have insurance and they have a doctor doesn't mean they get in to see their doctor. I'm rounding on the inpatient service this week, and I'm getting messages from my patients saying my next available appointment is in September. So, what do we do about all of that? I think there's a lot of populations that still remain very marginalized, and these can be a lot of minority populations, certainly immigrant populations, and a lot of indigent populations that may have what we call transient healthcare, meaning that they may have it for a period of time and then they may lose it and they're waiting to get it back. Accessibility is one thing, but also there's longer wait times. So I think the mammography screening and breast cancer screening while it can be accessible, it's still a challenge for a lot of populations that I mentioned, and even in areas around major health centers and major hospital centers in big cities, there are still a lot of marginalized populations. We have a growing homeless population, unfortunately, that's going to struggle with access to care as well.
It would seem that some populations have this access to mammography, but for other groups, screening has actually possibly decreased. And so has mammography screening decreased or actually increased disparities, and how?
It's a great question. I can't quote you numbers, but one of the biggest challenges we actually face is how to get people the access to what is accessible. So what I mean by that is it's not hard to get mammography because it's widely accessible and widely done in a lot of different centers. The challenge now is how do you get patients to their doctors to get the test ordered? How do you get patients to their primary care doctors to have a discussion about it? How do you get, we struggle with transportation issues for a lot of patients. We struggle with other things that may be more pressing in their lives. We have a lot of patients that are managing very acute illnesses, whereas if you're talking about a patient that may have just gotten out of the hospital or is fighting an acute illness, maybe prevention is not going to happen this week. And then that gets put kind of on the back burner as well. So in those populations, especially the very ill, and especially those that, again, I'm going to go back to not only indigent populations, but homeless populations and patients who have health care and access, and then next month maybe they don't. And it goes kind of in and out. Those are the ones that really struggle.
Yeah, so it seems to be that even once you're diagnosed, there are likely to be disparities in treatment as well, correct?
Absolutely. Again, it gets back to that accessibility. It gets back to all of the social determinants that create barriers in health. We've had discussions with patients about the importance of follow-up. I've worked with patients who have gone for mammograms and had abnormal findings, and then we have challenges finding the patient to tell them the results. So all of those things impact not only outcomes, but impact, of course, health equity.
And that's my final question, is that the authors do discuss health equity. Can you briefly describe what this is?
Sure. So there's a number of different definitions for this, and a number of different perceptions. CMS, or Centers for Medicare and Medicaid Services, defines it as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that impact social determinants, of course. And that's a big statement, and it means a lot, and it says everything, and we understand that. Our challenge in healthcare is how do we try to navigate around those disparities. I always say in my office, and my office is in a small urban center that has a lot of challenges with indigent populations and some homeless populations and immigrant populations. How do we break down those disparities and how to create health equity? And I always say it's harder than you think, because I only know the people that actually make it to my schedule. I don't know the people who I'm not their doctor and they're out in the community and they don't have the ability to get to my clinic and have us as physicians and then have us discuss these things with them to be able to get them the screening that they need and deserve.
Oh, absolutely. That's a whole nother discussion, I think. All right, I'm going to send it over to Megan for the next question.
Yeah, so moving on to our third article on incorporating value-based decisions in breast cancer treatment algorithms by Dr. Tan Wang and Dr. Leslie A. Dothit. So the authors suggest that patients with early stage breast cancer are at risk of overtreatment. Can you explain why this is the case and what steps can be taken to avoid overtreatment?
Yeah, this is delicate. We are blessed with the ability to have the technology to be able to screen for a very common cancer in the population, and we're able to do it with a lot of accessibility and a lot of accuracy. So now the challenge becomes, well, wait a minute, are we over screening? And beyond that, are we over treating? So as a humble family physician who's not an oncologist with a specialty in treatment of breast cancer, I try to focus on the first half of what we've discussed relative to screening the right people at the right times at the right risk. Based on that, now what do you do with the results? So the negatives are negative, great. That's what we want. The positives ultimately end up falling into these categories of staging. And, if we're screening a greater number, and if we're screening a greater number and finding things very early, ideally we want to find every cancer on day one. We don't want to find it late in the game. But now the challenge is, the earlier you find it, do we treat everything in a very early stage? Will some of those cancers regress? Can we observe some of those cancers? Do we need to operate on all of them? Do we need to give all of them chemotherapy or radiation therapy, et cetera? So what these authors talked about really was the risk of overtreatment. Of the earlier you find something, do you run the risk of overtreating it based on risk of overtreatment? And that's a very tricky thing. What steps can be taken to avoid the overtreatment? I think this is where the benefit of a multidisciplinary care team really plays to the patient's benefit, of being able to say, we have screened a patient for cancer. We have found this cancer. We believe it is in this stage. Based on the data that we have, these are the treatments that we recommend versus observation versus et cetera, et cetera, et cetera. And we can give you this likelihood because you're at this stage of, this is where things are going to be, and this is the best treatment for you. And I think that allows for a lot of great individualization of treatment.
Yeah, that makes sense. The multidisciplinary approach. It's very interesting. So moving on, the article also mentions tailoring treatment recommendations based on tumor biology. How does understanding a patient's tumor biology impact treatment decisions?
Yeah, again, I'm not an oncologist, but from this particular article and other things I've read, with something as common as breast cancer and the data that we have now, they can identify specific tumor markers, tumor biology, and then be able to say, based on this and based on these genetic findings and based on this particular stage, this is the best treatment option for you, or these are the best treatment options for you, and allow a patient to be able to choose those with the right follow-up.
And could you explain a little bit more about what de-escalation of care means? The authors mentioned this as well. So could you talk about that a little bit and how it benefits patients?
Yeah, again, I think things really need to be individualized. The easiest thing to say is, a patient has a cancer and these are the treatments you're going to do. And it seems very natural to have that kind of mindset. And I think that's what we do most of the time, and we do it well. When you're de-escalating care, that can either be based on models where you're moving toward achieving a cure, and a patient may have had a surgery and then doesn't need chemotherapy, or a patient has had certain rounds of chemotherapy and now we're going to follow the patient, or patients have had certain rounds of radiation therapy, now we're going to follow the patient. It's going to really come down to, again, that multidisciplinary team of the oncologists, whether it's a surgeon or a nuclear medicine physician through radiation medicine, to be able to determine what's best for the patient.
Yeah, I guess it rings true that it takes a village.
It takes a team.
And lastly, before I hand it back to John for our last article, There seems to be significant variability in recommendations from major organizations on which patients should undergo genetic testing. Can you provide some insights on when genetic testing should be offered to patients, in your opinion?
Sure. So I split this in a couple different categories, right? So there's genetic testing in terms of screening, and then there's genetic testing based upon tumor pathology. So genetic testing based upon screening, we talked a little bit about before, especially in situations where patients have had a family history, and especially in a family history at a very young age, and multiple family members. I'm thinking of patients in my practice who wanted to know if they were going to be at risk for developing breast cancer at an early age or at all. And I've talked to women in their 20s and women in their 30s, some teenagers. And genetic testing can be very, very useful because they've been able to, in many cases, identify a lot of the more common genetic markers that will allow a patient to make an informed decision and say, I have a 10% risk of developing breast cancer. Okay, I'm going to go through these particular screening routes, or I have a 90% chance of developing breast cancer. That might be, life-changing for them in terms of, do they pursue double mastectomy surgery, for example, or other potential avenues to learn what their risks are and prevent it. Based upon tumor biology, again, I think that also weighs in a lot of similar ways. If you had a patient that had breast cancer and had either a lumpectomy or a mastectomy, and then they did tumor biology based on the specimen, you can learn a lot from that as well. That can inform decisions that can go throughout the family.
Thanks for that, Joel. Yeah, it does sound like a lot of individualization, is what it really comes down to. Anyway, take it away, John.
All right. Well, Joel, the final article from the collection that we wanted to discuss is by Dr. Andrew Fenton et al. On multidisciplinary management of breast cancer and the role of the patient navigator. So patients with breast cancer now encounter a clinical team during their treatment. So which clinicians are part of this team?
Sure. So that can vary. There's almost always an oncologist, and there may be a surgeon. There may be multiple oncologists, as some have a specialty in medical oncology, surgical oncology. There may be nuclear medicine physicians, radiologists involved if there's radiation therapy as well. We're also seeing now in a lot of academic centers and other hospital centers where pharmacists are playing a role in coordinating medications, be it chemotherapy or the impact that chemotherapy and medication treatments may have on existing medications. A lot of patients, obviously, this is a major thing for patients in terms of impact on their life. There's social workers, there's psychologists, there's care navigators. There's a variety of folks that can help a patient through managing the diagnosis and managing various stages of the treatment. And then in most cases, our hope is always that this maintains some level of continuity with the primary care provider.
And how do they reach out to you as the primary care provider? I mean, the multidisciplinary team, do they keep you informed?
Sure. So here's where I'm going to put in a plug for the electronic medical record system. We don't hear many of those, but I'm going to put a plug in. I'm going to put a plug in for one. I think with a lot of these systems, it's easy to send people messages. We don't have to page each other and that sort of stuff anymore. But the ability to go into a patient's chart or send messages and communicate with your colleagues about a patient through the electronic medical record, I think has made it a lot easier.
You don't hear many plugs for that, so that's great news.
I have no disclosures to admit with any electronic medical record companies.
So in the article, the authors write about a new yet essential team member in a breast cancer treatment plan, a patient navigator. So what does this navigator do, and why are they considered so essential?
Sure. So in a lot of ways, they can be the quarterback for the healthcare for the patient. It's complex. I mean, we kind of take for granted that we're just going to send a patient here and send a patient there and go get this test, go get these labs done, go to this appointment here, go to this appointment there. It's very complex. It seems easy when we just direct traffic, but the role of the care navigator is really to help a patient through the experience and through the process. And that can be setting up appointments, making appointments, getting to appointments. Many patients have transportation issues, help supporting insurance needs, and also help fostering that communication across the team.
So are there specific qualities that make a navigator successful that you've worked with?
Anybody who communicates well and advocates for the patient.
Oh, that's good. Okay. So now the patient has gone through their treatment, and what can you tell us about the post-treatment patient and the multidisciplinary team? Are they still involved, or do new experts come into the picture?
That's a great question. From the primary care end, I'm going to see a patient back, and I either ordered the mammogram or I didn't. I either found the breast cancer or I didn't. But when I'm seeing the patient, now that I see that they have breast cancer, it helps to know, are you still under treatment? Have you completed treatment? How are you doing? What's your plan for follow-up? Because in a lot of ways, the primary care provider is still going to be the director of their healthcare and help them navigate through this. So we talk with our nurses, and we talk with our care managers, and we talk with our care navigators to help meet the needs of the patient. Is the patient doing well with this diagnosis? Are they struggling with this diagnosis? Do we need to help them get mental health resources? So it's really just a way to continue to foster all that communication.
Well, fantastic. This has been a great discussion about these 4 articles in the issue, and there happen to be 28 articles in this special edition of Breast Cancer of the Clinics Collections. So before we go, I wanted to ask whether you had any final thoughts about this issue.
It's a privilege, as always, to work with you, but also, to put this together. We have a lot of great manuscripts in this clinic collections. It was a pleasure to put it together, and I think what we've tried to do is represent a very multidisciplinary approach. This isn't just primary care. This isn't just surgery. This isn't just radiation oncology. It certainly encompasses all aspects, and I hope the readers find this to be useful and practical.
Well, thank you again.
Yeah, thanks a lot for your time.
Thank you.
Thank you for joining us for this edition of the Clinics Review Articles podcast on breast cancer with Dr. Joel Heidelbaugh. To purchase this Clinics collection on breast cancer or other recent editions on heart disease, COVID, telehealth, or addiction medicine, please visit us.elsevierhealth.com. For more information on the Clinics Review Articles program, which spans nearly 60 medical disciplines, visit www.theclinics.com. Be sure to follow us on Twitter/X @Clinics Reviews, and subscribe to the Clinics Review Articles podcast at theclinics.com or on most major streaming services, including Apple Podcasts, Spotify, and YouTube. Thanks for listening.